So I want to introduce Dr. Bobby Chhabra, the chair of UVA Orthopedics, who's my good friend and mentor. He has really been a guide for me as far as how to become a doctor. When I was a medical student rotating here at UVA, Dr. Chhabra was the program director, and I did my best to try to impress him back then, hopeful that one day he would give me a job here at UVA on faculty. And so here we are. It looks like that I answered some questions right when I was a medical student. So anyhow, he is the premier elbow upper extremity surgeon here at UVA, and helps take care of a lot of these injuries in our athletes. And so I think we'll have a lot of fun talking about ulnar collateral ligament injuries and reconstructions. And so again, if you have any questions, please put them in the chat. And otherwise, I'll turn the channel over to you, Dr. Chhabra. Thank you for being here.
Great. Can everyone see my screen and hear me okay?
Yep. It looks perfect. Thanks.
Great. Thank you again, Dr. Guathmy. And just before I start, I'd like to just make one comment. I trained with Dr. Frank McHugh here when I was a resident and a med school and resident, and he gave me the opportunity to come return and help care for UVA athletics and many other local high schools and other colleges in the area. And as many of you know, Dr. McHugh was a sports surgeon, but also a hand and upper extremity surgeon. And he was fellowship trained in hand and upper extremity. So I had the fortune of being asked to return to take over his hand upper extremity practice. So and I was thrust into caring for UVA athletes when I returned after my fellowship in 2002. So I've been helping care for UVA athletes and many high-level athletes in our community since that time. And one of the most challenging groups of individuals to care for are baseball players here at UVA, particularly since they are defending national champions a few years ago, and they're a very high level team. But also our community has a very robust baseball program, and I have the fortune of working with Winston Guathmy, who's our head team physician for baseball, and he really does a tremendous job taking care of UVA baseball. And Brian McGuire is the trainer for UVA baseball, who I've worked with for as long as I can remember. And he and I and Winston have learned a lot together, and we've had the fortune of caring for an incredibly talented group of athletes and working with great coaches. So I'm very privileged to work with Dr. Guathmy and Dr. McGuire caring for UVA baseball players, as well as many of the athletes in our community. But one of my favorite topics is elbow injuries in the throwing athlete. And there's several injuries that can impact a young thrower, but the one I would like to focus on is the most common that people hear about is the ulnar collateral ligament of the elbow, and injuries and treatment options. So I'm going to go through this, and happy to take questions afterwards when we're done. So the elbow is a very interesting joint. It's a hinge joint. So it is a hinge, but there's also some rotational component to it. But for the main part, it's a hinge joint, and there's the ulnar humeral articulation, then there's the radiocapitellar articulation where you can pronate and supinate your forearm. And bones overall provide 50% of the stability. The rest of the stability of the elbow is provided by the anterior joint capsule, the ulnar collateral ligament complex, and the lateral collateral ligament complex. And you can actually see these. So here's the LCL. So this is the lateral side of the elbow. So the annular ligament, the accessory collateral ligament, and the lateral collateral ligament. We don't often see problems in throwing athletes on the lateral side of the elbow, but after elbow dislocations, traumatic elbow dislocations, patients can have problems with posterior lateral rotary instability because the LCL has healed in a lengthened position. But what we're going to focus on tonight is the ulnar collateral ligament, which is composed of 3 parts. So that's on the inside of the elbow, the medial side of the elbow. So it's composed of the anterior bundle, the posterior bundle, and the transverse bundle. And most of the pathology that we deal with is the anterior bundle in a thrower. And you can have injuries to the posterior bundle as well, but the majority of problems that we deal with in a high-level pitcher, or any pitcher really, who has medial elbow pain, there's always a concern for a sprain or complete rupture of the anterior bundle of the ulnar collateral ligament. So just to give some epidemiology, and Winston, you'll recognize some of these slides. So just a little throwback. I was looking through some of my talks about UCL, and I found a talk that Dr. Glafny gave as a chief resident. So there's some slides from his talk as I was putting this together for tonight, and some of those are historical talks. So Dr. Glafny, I think you'll enjoy seeing some of these slides, a little blast from the past for you.
Of course.
But there's quite a few, 1.7 million high school throwing athletes in this country, 90,000 NCAA throwing athletes. Little leaguer, there's 37% of little leaguers have shoulder elbow injuries during their playing time, 20% of high school players, and 24 to 34% of NCAA baseball players have shoulder elbow problems. And at the professional level, it's a much higher incidence of problems or injuries. So what type of injuries does an overhead throwing athlete have? It's the UCL, or the medial collateral ligament or ulnar collateral ligament, is the one that everyone has heard of. It's the most common. But you can also have something called valgus extension overload syndrome, which I'll talk about. Cubital tunnel syndrome is the irritation of the ulnar nerve, and often it precedes UCL injury, because these throwers are throwing so much that they start getting irritation of the ulnar nerve prior to them having an injury to the UCL. So it could be a warning sign. It can also happen if someone has a subluxating ulnar nerve, and if they're throwing quite a bit, they can get ulnar neuritis. Osteochondritis dissecans of the capitellum is a topic that I have done quite a bit of research on in surgery. It's one of the topics I've published on extensively, but that's usually seen in slightly younger throwers than the high school and college level thrower. But it's a vascular insult to the cartilage of the capitellum because of repetitive activities, and you end up sloughing off your cartilage, and it's a challenging problem to care for, but that's a topic for another lecture. Little leaguer's elbow is when they're younger and their growth plates are open, and they have what's called epiphyseolitis, or a stress reaction along their growth plate, and it's usually on the medial side of the elbow. You can get it in the olecranon too, and we do see that in throwers. But once the growth plate closes, so when the growth plate is open, it is the weakest part of the elbow. So in a thrower, that's where the stress is, and they get a stress reaction there. But once the growth plate closes and they've passed through puberty and they're reaching adulthood, the ligament becomes the weakest part of the elbow once the growth plate fuses. And that's why you have a transition from little leaguer's elbow, which is a growth plate stress reaction, to ulnar collateral ligament injuries as they get older. And then you can have some common overuse injuries, medial and lateral epicondylitis. And again, those are much more manageable than some of the other issues that I've discussed or that I've listed. So what do you need to know about a thrower? So there's 5 stages of the throwing. There's the wind up, there's the cocking, acceleration, deceleration. So actually in cocking, there's cocking and late cocking, acceleration, deceleration, and follow through. So if you look at these pictures, usually the injury occurs during the late cocking and acceleration phase. So look at the position of the elbow in these pictures. People who have valgus extension overload syndrome, which I'll explain later in this talk, have pain through follow through. But what's an interesting thing that I think many of you take care of throwers, you see where the pitcher's shoulder is here. And often these pitchers have what's called glenohumeral internal rotation deficit. So they have excessive external rotation and limited internal rotation. So they can excessively externally rotate their shoulder, and all throwers have this. And if you compare them to their contralateral elbow, they can't externally rotate their non-throwing shoulder as much as they can their throwing shoulder. So a pitcher is taught to throw from their highest, with their shoulder at their highest point. But as they fatigue, as the season goes on and as they pitch more and more, they tend to drop their shoulder. And when they drop their shoulder, that allows them to externally rotate their shoulder more. And when they externally rotate their shoulder more, and you can see my pointer here, as they externally rotate their shoulder more, the stress occurs more along the medial elbow. And that's when they have injuries to the ulnar collateral ligament. It's really a mechanics issue and a fatigue issue in many scenarios. And I've been operating on these and these individuals for some time, and there is always a spike in December and right around June and July. So it happens after fall ball, when people are fatigued and they've been playing, and then it happens after the spring season. So there's always a bimodal spike in terms of the number of UCL reconstructions we do. So my partner, Richard Dacus, takes care of JMU baseball, JMU athletics, and I provide care for hand upper extremity care for UVA athletics. And he and I are extremely busy. Last December, before COVID hit, we did 12 UCL reconstructions in 4 weeks between the two of us. So but then since COVID, it's been very quiet, as you can imagine. But we tend to see these injuries at the end of fall ball and the end of spring ball because the pitchers are fatigued, they've been throwing, and their mechanics suffer, and then they tend to put excessive stress on the medial side inside of their elbow, and they often injure their UCL. So late cocking and acceleration are the phases where the injury occurs, particularly if their biomechanics suffer. So again, this is the 5 stages of throwing, and late cocking and acceleration are the stages where injury tends to occur. So this is some specifics. The wind-up phase is about 0.5 to 1 second. The stride phase is approximately 70 to 80% of an athlete's height, and it's 0.5 to 0.75 seconds. The cocking phase is 0.1 to 1.5 seconds, depending on the velocity of the pitch, and usually abduction is 80 to 100 degrees. External rotation is 165 to 180 degrees, and the compressive force is pretty significant. Arm acceleration phase, the angular velocity can reach as high as 7,000 feet per second, and the joint forces are tremendous. And then there's follow through. So, sorry. So if you look at the comparison of pitches, fastball and slider are very similar. They have the greatest segmental annular velocity and the highest torque and force on the shoulder and elbow. And curveballs have the highest angular velocity on the elbow. And I frequently see young pitchers who present to me because they were throwing curveballs and they felt a pop during throwing a curveball, and it's pretty clear to me what happened. They had to present with medial elbow pain, and it's because the highest angular velocity on the elbows during a curveball. So when a pitcher comes to me with medial elbow pain or any throwing or overhead athlete, you need to think UCL injury, medial epicondylitis, ulnar nerve irritation or compression, and if they're younger, little leaguer's elbow. So let's talk about the UCL. As I mentioned, the anterior band of the anterior bundle. So this is the anterior bundle is right here. The anterior band of that anterior bundle is the primary restraint to valgus stress from 0 to 9 degrees. The posterior band, so not the posterior bundle, but the posterior band here, so the inferior portion of the anterior bundle is the primary restraint to valgus stress in higher degrees of flexion. And rupture occurs due to repetitive high velocity and valgus stress to the medial aspect of the elbow. Improper mechanics, inadequate condition, high pitch point, pitch counts, fatigue, and poor flexibility all contributed. And the most force is during late cocking and acceleration, as I described, and that is when injuries tend to occur most. And elbow valgus stress, and this is a very important point, elbow valgus load, so stress on the ulnar collateral ligament, increases with poor throwing mechanics. It's because the shoulder drops. To generate velocity, they externally rotate their shoulder more, and that puts the fulcrum of their throw becomes their medial elbow, and that puts more stress on the ligament. And over time, the ligament will fail, particularly with pitch counts and fatigue. So how do these individuals present? They have medial elbow pain. They may have heard a pop, but frequently they don't. May have some swelling and ecchymosis, but that's pretty rare. But what they'll notice, and they'll almost every time, they'll feel some discomfort, but they'll keep pitching, particularly the younger kids who don't understand that they need to speak up when they feel pain. but they'll notice a loss of velocity and a loss of control. And this is significant. And this is the first question I ask. Did you feel a pop or not? Where does it hurt? They'll point to the middle. And I said, did you try to pitch afterwards? They'll say, if they say yes, I said, did you have any loss of velocity or control? And 100% of the time, if they have a significant UCL injury, they will say yes. They did not have the velocity or the control they had prior to the injury. On exam, they'll have tenderness over the medial side of the elbow. They may have some sensitivity over the ulnar nerve. The ulnar nerve is right there. And they may have some neuritis from the injury because of inflammation and swelling. And then you want to test the UCL. The valgus stress test tests the anterior band of the anterior bundle, and the milking maneuver tests the posterior band of the anterior bundle. And if they have pain in any of those maneuvers, you should assume they have an injured ligament. And they may have laxity, pain, or apprehension. If they have any apprehension, that is a red flag to me, and I need to consider a UCL injury. And let me just show you. So a valgus stress test here on the right is the anterior band of the anterior bundle may be injured. And then the milking maneuver, the valgus stress was on your left and the milking maneuver is on your right. But the player can do it themselves. But if they put themselves in that position and they have medial pain over the medial epicondyle region and the flexor pronator mass, then that suggests a posterior band UCL injury. So how do you evaluate them from an imaging standpoint? Always get an X-ray. You'll be surprised. If they have an open growth plate, they may have had a medial epicondyle avulsion. And so they have an avulsion fracture that may require open reduction and internal fixation. If their growth plates are closed, they may have a small little avulsion there, as you see in the image there where the arrow is, that would suggest a UCL injury. You can do stress views, but this is difficult sometimes, particularly if they're acutely painful. I tend to do stress exams a few days afterwards, once their pain is a little bit improved, so I can get a good exam. But it's hard to do a stress view and actually convince yourself there's a UCL injury. They may have medial pain, but on imaging, and if you have a fluoro image like they show on the right or an X-ray, because the radial head is intact and that's a stabilizer to valgus stress, you won't get any real significant opening. So that's not as useful of an exam. But if they have pain, you should be, again, concerned that there may be a UCL injury. MRI arthrogram is the diagnosis, the imaging test of choice. So if you examine them, they give the history, you suspect it, X-rays are often normal. MRI arthrogram, not a regular MRI, because a regular MRI will miss 50% of injuries, particularly mid-substance injuries. So an MRI arthrogram is the test of choice, and every pitcher who has an injury should have an MRI arthrogram if you're concerned for a UCL injury. It's also true for lateral collateral ligament injuries, but again, we're focusing here. So what's an arthrogram? They inject dye into the joint and then they get an MRI. And in here, you can see where the arrow is. There's a disruption of the UCL and there's actually leak of the dye outside of the joint. And that's what you're looking for. So here is a normal UCL. Here's the UCL origin here. Here's the ligament. And here is the insertion on the sublime tubercle. Okay. There's fluid here. There's no leak of the fluid outside of the joint. Now, if you look here, and again, this is the T sign here, contrast will escape outside of the joint because there's a tear here. And it's most commonly off the sublime tubercle, but I just recently saw a pitcher who had a tear off the medial epicondyle, a complete tear. And that, while that's less common, it's still it's the same functional outcome. They likely need intervention to get them back to pitch. This is a high-grade mid-substance tear, and it's also, there's a T sign here. There's a leak of dye here, but there's signal here suggesting a sprain of the ligament. And in this case, it involves the entire width of the ligament, so it's a high-grade mid-substance tear. So how do you treat UCL injuries? A partial tear is considered a sprain, and if it's this is patient specific. If this is a first time injury and it's a partial or low grade sprain, or partial tear, you can treat this non-surgically. No throwing for 3 months. You can try a brace to protect against valgus stress. Once they're not symptomatic, which may be after a couple weeks, you can initiate therapy for flexibility, endurance, and you want to strengthen the flexor pronator mass. Some of the muscles around the elbow, particularly the flexor pronator, provide dynamic stability to the medial side of the elbow. The anconeus does on the lateral side of the elbow. So you can strengthen the elbow, and that's a very important part of their rehabilitation. Once they're asymptomatic and you've waited 3 months, you can return them to a graduated throwing program. I use the Andrews throwing program. They start slowly, they advance slowly. It usually takes about 6 weeks to get through the throwing program before they can pitch competitively and from the mound. So it's a fairly long rehabilitation. What about surgery? If you have a complete acute rupture, or essentially high-grade tear or full thickness tear, or failure of 3 months of conservative management and failure to progress through a throwing protocol, or they have had recurrent problems. They've tried to treat it non-surgically and they've rehabbed and they've gone back to throwing and they have a recurrent injury. In that scenario, it's called chronic insufficiency. UCL surgery is indicated. And there's some debate here. If you have an acute rupture, some friend of mine, Dr. Dugas in Alabama, is doing acute repairs with biologic collagen tape. And he did that in high school pitchers, starting to do it in professional pitchers. The thought was that they could return a little bit, they can return faster. But still, the gold standard is a UCL reconstruction for an acute rupture. And chronic insufficiency, or for a chronic insufficiency or chronic rupture situation, a UCL reconstruction is also indicated. And that's known in layman's term as Tommy John surgery, although there's a lot of different types of Tommy John surgery. One point I want to make with partial tears, and many of you have heard this, for the last several years, I've used PRP, platelet-rich plasma, for high-level baseball players with partial tears. It is an adjunct. We have a PRP machine at the hand center. I will use it. Sometimes Dr. Guathmy, who has ultrasound skills, will come over with his ultrasound and help me inject make sure the ulnar nerve's okay, or inject the area of injury. But you can use it as an adjunct, but it doesn't necessarily mean they'll return at a faster rate. We still tend to be very conservative with partial tears, but we use PRP as an adjunct for healing. And there is some support in the literature that it may be beneficial for some individuals and some partial tears or sprains. So what is Tommy John surgery? So the initial description was in 1986 by Job. And it's a reconstruction of the ulnar collateral ligament in athletes. But this was the case, and Tommy John was the first case. He was a 29-year-old pitcher who complained of pain from the medial aspect of the elbow for 3 months, tenderness over the UCL. There was ossification just medial to the elbow joint, and this was felt to be an old avulsion. The area was injected with steroids 25 times over 8 years, something we would never do now, but again, this is the history. So he had medial elbow pain as a pitcher, and he was injected 25 times. The elbow was painful when the patient was 12 years old and pitching in the Little League. And after 2 years of rest, it became asymptomatic. 2 years of rest, and he began to pitch again. So this is what he went through, Tommy John. He had a avulsed medial epicondyle fragment excised in 1972. He pitched the 1973 season with one episode of pain. He pitched well in 1974. He was 13-3 when severe pain after a slider, and he felt his elbow give way. He had a avulsed medial epicondyle fragment. Again, that's explain that, but stress views at that time showed 45 degrees of laxity, and he was casted for 6 weeks in persistent pain with throwing after he returned. So in September of 1974, he underwent a UCL reconstruction by Job. And at that point, they took down the flexor pronator mass, and they used They drilled tunnels through the ulna and medial epicondyle, and they did a figure-of-8 contralateral palmaris tendon graft, and without an ulnar nerve transposition. So this was the surgery. This was the first surgery by Job, and this was the Tommy John procedure. So how did he do? So he had a dense ulnar nerve palsy for 3 months post-op. It was explored and found to have scar tissue band. Scar was excised. The nerve was transposed submuscularly. He regained sensation and motor over 13 months. He restarted pitching at 9 months. Rehab completed at 18 months, and he returned to work April 1976. First season, he went 10-10. Second season, 20-7, pitching at 89 degrees. His elbow lacked 20 degrees of full flexion. And many of you know, if those of you who follow baseball know the story, that he used to be a fastballer, and then he really changed and increased his pitching repertoire after his surgery to be more of a junk baller, and he was very successful. So after that initial surgery, Job did 16 UCL reconstructions between 74 and 82, and he published the paper in 86. All throwing athletes, mostly baseball players, they all failed conservative treatment, and he used palmaris autograft in the figure-of-8 configuration. And he routinely transposed the ulnar nerve after Tommy John's initial experience with where he had a dense ulnar nerve palsy post-op. He mobilized the elbow at 2 weeks, strengthened at 4, gradual return to throwing once the swelling and pain was better, and full speed throwing at a year. 10 of the 16 returned to the previous level of performance, 1 to a lower level. 5 retired from pro sports, not as a result of the procedure, and 7 of 16 returned by year 1, 4 at 18 months. There were 5 complications of ulnar neuropathy, and 2 requiring second procedure out of 16 patients, so very high complication rate. So since 1986, when Job performed this, surgery gained great public attention. Previously, UCL injury was career-ending for pitchers, and players would often report their elbow felt stronger after the reconstruction. So some of that is a myth, because many of these pitchers were pitching with pain for a very long time. But still some concerns. 20 to 30% at that time did not come back to prior level of performance, and a lot of them had ulnar nerve symptoms. And as many of you know, there's a book called $1 Million Arm that pitchers are the highest paid athletes in probably the world in many ways. And so this became a high, very scrutinized and high level and a scrutinized procedure, because for many individuals, the UCL reconstruction was a way for them to continue to make a living. So Dr. James Andrews helped revolutionize this procedure. And Dr. Andrews is a mentor to me and many of our faculty. He was a pioneer of shoulder, elbow, and knee and surgical techniques and rehabilitation. He was Dr. Frank McHugh's first fellow in sports medicine. Dr. McHugh was a mentor to many of us, obviously, at UVA, and then a mentor to me. But I had the opportunity to spend several weeks with Dr. McHugh Dr. Andrews after my fellowship. And when I finished my fellowship and came back to UVA to join faculty, McHugh sent me down to spend 2 weeks with Andrews, just watching him do Tommy John surgeries. And it was an unbelievable experience. And Dr. Andrews is still an advisor to me and Dr. Gwathmey and many of our providers who care for high-level athletes. We call him frequently, we talk to him frequently, and he's a great alumnus and a great mentor. So since 1986, there's been a lot of modifications. Job was the figure-of-8. The docking technique was developed by Allcheck. The Andrews modification by Andrews. The modified Job by Yoakum. The interference screw technique by Elatruche. The hybrid technique by Elatruche. The modified docking by Paletta. And there's a lot of others. So you've heard a lot of these names because a lot of these individuals are taking care of the highest level baseball, but all the professional baseball players in this country. So when you look at this operation, there's still some fundamental questions. What do you do with the ulnar nerve? What do you do with the flexor pronator origin? What do you do with humeral fixation? And what is your graft? What's the best graft choice? You have options for palmaris, plantaris, gracilis, the contralateral gracilis, and toe extensors. I can tell you I use palmaris if they have it. ipsilateral palmaris. If they don't, I use the contralateral gracilis. And I often have Dr. Glockney or one of my sports partners harvest the gracilis for me while I'm exposing the elbow. So they get me a gracilis graft if I need it. But if they have a palmaris, I use the ipsilateral palmaris graft. So here's the Job figure of 8. So this is a picture of that procedure. The docking technique by Olchak. This is a flexor pronator muscle splitting approach. And the safe zone 1 centimeter distal to the sublime tubercle. The ulnar nerve is not transposed. And basically, the flexor, you make bone tunnels distally, and then you dock it on the posterior aspect of the humerus through a bone tunnel. So the flexor pronator is split, a single humeral tunnel where the ends of the graft are docked and the sutures are tied over an anterior bone bridge. The Andrews technique, again, you see the ulnar nerve is transposed here, and the flexor pronator mass is elevated. The nerve is transposed, and the graft is secured with a figure of 8 weave. So it's similar to Job, but just a little modification. The modified Job is a muscle splitting figure of 8 with no transposition. So it's a muscle split and no transposition. But it's the same figure of 8 that Job did. Alatrust is an interference screw, and I've gravitated to this type of fixation now with the suture anchors and interference screws that we have. And over the last 2 or 3 years, it's been incredibly reliable for me. It is a very powerful way to reconstruct the ulnar ligament. The hybrid technique by Alatrust, and I did this for some time as well, was an ulnar interference screw and humeral docking, and the posterior graft is tension and flexion, and the anterior graft is tension extension to make it as tight as possible. Plato was the modified docking, where they use a quadrupled palmaris graft, and this can be a challenging procedure, and it's hard to get enough length of the palmaris graft in most people. So as you can see, there's different techniques, but all of them reconstruct the ulnar collateral ligament, but along the course of its origin at the humeral condyle, the posterior humeral condyle, and the insertion on the sublime tubercle. So regardless of how you do it, that is what's done. You're taking a tendon and you're recreating a ligament. So and I always tell my baseball pitchers is, in many ways, that tendon you're using has to become a ligament in your body. And this is just sort of a simple way I explain, because often people ask at 4 or 5 months, I feel great, why can't I throw? And my answer to that is, I used a tendon to recreate a ligament. That tendon has to become a ligament in your body if you're going to be able to throw. And you can't rush biology, and it takes time for that to happen. And maybe that's a simplistic way to explain it, but everyone seems to understand that, is that it takes time for that tendon to become strong enough and become ligamentized, is the way I like to describe it. And whether that actually happens or not, it's a very good way to explain to individuals to say why you have to be patient. Because the worst thing that can happen is if you send someone back too early and they re-rupture it, because the return to throwing at the same level with a recurrent UCL reconstruction is very low. So how about rehab? A mobilization of the elbow for about 2 weeks, sometimes less. Start shoulder and elbow range of motion, often in a brace. Strengthening at 4 to 6 weeks. No valgus stress until 4 months. They're often like, when can I do bench press? And when can I do push-ups? I don't let them do them until 4 months. They can start tossing a tennis ball at 4 months, light throw from a wind-up at 6 months, and then graduated program of range of motion strengthening and total body conditioning at 7 months, 50% throwing effort, 70% max velocity at 9 months, throwing in competition at 1 year if no pain and full range of motion, 18 months before return to previous level of play, and rehab should be carefully supervised by trainers who understand this protocol and understand this very specifics of the throwing protocol. The one thing that I often tell my pitchers is that you may be able to return to at 12 months, but you won't feel like you are at your maximum improvement till more like 15 and 18 months. And that's pretty consistent. And Steven Strasberg didn't return till almost 2 years after his surgery, and they really limited his throwing for many months. They shut him down when the Nationals were going into the playoffs because they didn't want to have him re-injure his elbow. So you have to be careful during this time, and it is a very prolonged rehab. And I often tell my patients the easy part is the surgery, because the surgery takes me an hour and a half or 2 hours. The hard part is the rehab, and that takes a lot of patience. So if you look to return to previous levels of performance, it's improved significantly. The Job technique, the old way, there was a 63% return to previous level of performance. But then as you see, Andrews and additional surgeons we've done more and more and have become more experienced with this, the muscle split, the docking technique, some of small case reports have reported a 97% return to previous level of performance. So there is variability. So let me review some of that literature. The outcome of elbow ulnar collateral ligament reconstruction. These are some older papers, but they are very significant because there are a large number of cases. This was 400. This was Ahmad up in New York. 405 UCL reconstructions, looked at outcomes and post-op complications. Overall, 83% excellent results, 10% complication rate. That's a high complication rate. 6% had post-op ulnar neuropathy. They did a muscle splitting. They felt muscle splitting was better than detachment of the flexor pronator mass. And they abandoned the ulnar nerve transposition because they felt they had less problems with neuritis. The docking technique was associated with better outcome than figure of 8. And then more recent literature, 1,266 UCL reconstructions over a 19-year period. 83% return to play at the same level, 20% complication rate, ulnar neuropathy, and 16%. One patient with a complete ulnar nerve motor and sensory dysfunction, and motor returned after a secondary neurolysis procedure, but they still had persistent paresthesias. So let me just switch gears a little bit, and I think timing is okay. So I'll be done in the next 5 minutes or so, and we can take some questions. But one thing that I want to talk about a little bit is something called valgus extension overload syndrome. So often when throwers have acute or accumulative injury, they get medial elbow pain. And if they heal and they continue to throw, because they'll often develop a little elbow contracture, which is protective, and they'll modify their throw a little bit. They'll increase the number of pitches they throw so they can be effective and competitive. But they may develop some chronic mild insufficiency where they have pain from time to time. And what happens is that the ligament, there's laxity on the medial side, and they end up rubbing the medial olecranon in the olecranon fossa, and they'll end up getting bone spurs. So you'll see that there will be laxity here, and they'll rub up against their olecranon, and then they'll develop big bone spurs in the back of their elbow. And many people felt that this is protective because by building up those bone spurs, they have less laxity on the medial side because of ligament incompetence or ligament insufficiency. So I'll often get x-rays with individuals who've had a long history of medial elbow pain and have continued to pitch. They have these bone spurs in the back of their elbow, and it's felt to be protective in many ways, but they end up having posterior elbow pain because of these bone spurs in the posterior olecranon fossa. And they tend to have pain in follow through. So when their elbow's coming out to extension or neuro-extension, they'll get posterior pain, and it can be very debilitating. So because of that, and they can also end up getting ulnar neuropathy because of that laxity on the medial side. And as they get more lax on the medial side, and even though they develop bone spurs in the olecranon fossa, they'll impact their radial joint, the radial head against their capitellum. And over time, they'll get radiocapitellar arthritis. So some of the worst looking elbows are these pitchers in their 20s who have valgus extension overload syndrome, have continued to pitch, haven't had surgery, and they have bone spurs and osteophytes in their posterior olecranon fossa, and they also have radiocapitellar arthritis. And that's a very difficult problem to deal with. But that's what happens if you don't treat these individuals when they have acute ruptures. They can have chronic insufficiency. So UCL laxity or attenuation leads to valgus subluxation during extension, and the force is transmitted around the joint to the radial side. So you have UCL laxity first, you have posterior medial impingement here, you have ulnar neuropathy because of stretch of the nerve on the medial side, you have increased capitellar loading, and you have radiocapitellar arthritis and chondral defects. So this is sort of end stage of chronic insufficiency of the ulnar collateral ligament, something that we want to avoid in pitchers. So how do these individuals present? They have pain during late acceleration and follow through. Imaging MRI arthrogram will also show a chronic UCL tear. And in these individuals, it's a tough problem. You can treat them with rest, anti-inflammatories, maybe a posterior elbow injection. You can try strengthening and try to progress them to a graduated throwing program if they do have a flare-up of pain. But if they end up having surgery, they need to have an elbow arthroscopy first, where you put a scope in and you debride the posterior elbow joint and the olecranon osteophytes and the olecranon fossa and remove any loose bodies. And once you do that, remember those bone spurs were there to try to protect against medial collateral, ulnar collateral ligament instability. So once you remove the bone spurs, the ulnar collateral, the medial side of the elbow is more lax. So you often have to scope the elbow first and then flip them and convert to do an open UCL reconstruction. And those are cases that I've had to do. Fortunately, less common than acute UCL reconstructions, but this is a situation in a chronic UCL where you have to scope the elbow, clean up the osteophytes and bone spurs, and then do a UCL reconstruction. And here is an example of bone spurs in the back of the elbow right here that we had to debride, and this is post-debridement of this huge bone spur right here. So what do I do? So I tend to do a docking reconstruction technique and have been doing that. The first probably 8-9 years of my career, I did the Andrews technique with the loop over, but I often realized that the palmaris length was not always great. So I converted to a docking technique. And now I've converted over the last 2 to 3 years, sort of an interference screw technique, because I feel like I can tension it much better. And I also not only do a palmaris graft, but I use a collagen tape biologic as well. So I like to reinforce my palmaris graft with a collagen tape as well. So it may be a little overkill, but I've been very pleased with the strength and recovery, and it's been much more predictable in the rehab over the last few years for me. I do a muscle splitting approach. I use a palmaris ipsilateral, and if not, I use a contralateral hamstring. And I tend to do an ulnar nerve transposition. If you look at the literature, the sports guys who do this, they don't like nerves, and they don't transpose the nerve. But as a hand surgeon, I do ulnar nerve decompressions all the time. I'm very comfortable with that. And for me, I just feel it's more predictable for me if I transpose the nerve and get it out of the way, because frequently the ulnar nerve palsies and so forth are because of the ulnar nerve being in proximity to the drill holes you're creating and while passing the graft. So I like to move the nerve away from where I'm working and placing the ligament. But that is still a little bit controversial. But for my entire career, I've been doing an ulnar nerve transposition and felt it's been very reliable for preventing any post-op complications. You saw what a significant number of patients had post-op complications, and many of them were related to when there wasn't an ulnar nerve transposition performed. And here is an example of one of my cases with a docking technique. So in conclusion, injuries of the elbow are very common in overhead throwing athletes. Throwing mechanics are super abnormal, leading primarily to overuse injuries, and awareness and improved mechanics can prevent injuries. This can be a career-ending injuries in overhead throwing athletes. So reconstruction is often the option, particularly those who want to pitch at the next level. I can tell you, if you're a non-thrower, I have UVA football players, our linemen have complete ruptures of the ulnar collateral ligament, medial collateral ligament all the time, and none of them need surgery. You put them in an elbow brace and send them back out on the field. If you have an intact radial head and you have other structures that are intact, they don't need surgery. The only individuals that I do this operation are overhead throwing athletes. So baseball pitchers, I've done about half a dozen of our javelin athletes over the years here. Javelin, as you can imagine, is a very stressful on the medial elbow, and I've operated on a couple of our volleyball players, but it's mainly baseball pitchers and baseball players and some softball players. You're not going to need to do this. You will never read about a football quarterback that you just don't throw with enough velocity and with enough flexion of external rotation of the elbow in a quarterback, and in any non-throwing athlete, you just don't, the medial collateral ligament will heal sufficiently enough, and you have other constraints in the elbow for stability where it's not needed. So this is a reconstruction for throwers or overhead throwing athletes. Numerous reconstruction techniques are available. Post-op techniques are similar despite the technique. So everyone uses the Andrews protocol. Post-op protocol is what I described. There's no guarantee that athletes will return to pre-injury level of throwing. But the literature is better than when Job did it. It was about 60%. Now I think it's around 80 to 90% all in. So you do need to counsel these pitchers that you may be able to throw when we're done, but it doesn't guarantee you're going to get back to the same level of pitching that you were. There may be a 10 to 20% chance that you may not return to your pre-injury level of throwing. And that's a very important conversation to have prior to surgery and not after surgery. Complication rates are not insignificant, and ulnar nerve complications can be devastating. So you need to be very careful around the ulnar nerve during this approach. So that is my talk. I hope it was helpful in many ways, and I'm happy to answer any questions. And I really hope it was something you all were looking for. And if there's anything I didn't cover, I'm happy to cover it now.
Perfect. That was awesome, Bobby. I really appreciate it. Again, Dr. Chhabra is the expert. He did this, the book that he's referencing. I think this is a copy of it. To Jeff Passero with the arm. It's a good book if you want some light reading. It's interesting that this industry of elbow injuries in pitchers, and it's funny looking at that talk, Dr. Chhabra. There's some of those slides. That Tommy John case report. I went through that in detail. I think it's so cool, the evolution of how we get to where we are today from a treatment standpoint. And there was an earlier talk that Robin West had about ACL reconstruction. And one of the questions from the audience was, do you think further innovation in ACL will be surgical technique or rehab? And Robin West astutely said it will be a combination of both. And I think we've done a lot of good work as far as UCL reconstruction and refining our technique. But really the rehab ends up being as important, if not more so, as far as how to get these athletes back to their prior level of performance, if not a higher level. So Dr. Chhabra, we have a couple questions from the crowd. Brian McGuire is here. It's not uncommon to have MRI documented UCL thickening. Some seem to be clinically painful and others more of a, quote, normal finding with minimal clinical correlation. Ultrasound studies seem to show inconsistent results. What are your thoughts on this type of MRI finding? That is the MRI documented UCL thickening.
Yeah, that's a good question. And Brian McGuire is as much of an expert as I am in this. And he knows the rehab better than anyone. So, Brian, that's a great question. I think MRI thickening suggests probably previous injury and previous healing. And again, based on their symptomatology is how you should treat them. So they may have had a thickening and healing and they're minimally symptomatic, or they have adjusted their biomechanics and they're not stressing that portion of the ligament as much anymore in their throw, and they're able to participate. Whereas others, it's a suggestion of a previous injury with healing, but they have some subtle chronic insufficiency and they have symptoms during their throw. They may have recurrent symptoms or may not be able to progress through their throwing program as we try to rehab them. So sometimes these findings can be equivocal or inconclusive. But on my mind, you have to look at their symptomatology. You have to figure out, are they maintaining their same velocity? Are they maintaining their same control? And if they're not, we need to consider that this may be an insufficiency issue, not your classic acute UCL rupture finding, but maybe an old injury that's healed, but there's some subtle insufficiency, and that's impacting their effectiveness as a thrower. And you should take that into consideration when determining your treatment.
Thanks, Tommy. Justin Dimmitt asks, when do you recommend PT to start after an autocollateral ligament reconstruction? And does it change depending on your technique?
No, it doesn't change. Usually within the first 7 to 10 days. When I first started these cases, when I came into practice, I was very conservative and I waited a full 2 weeks. But often we're starting range of motion regardless of the technique, because despite the technique, the same concept is true in every one of these cases. You're using a graft to reconstruct the UCL, and despite your fixation techniques, it's pretty safe to start rehabbing them. Remember, this is not an elbow dislocation situation. This is not a concern where you're going to have elbow instability. You will not stress the ligament through a regular range of motion. The stress will come when you do overhead throwing. So you can start normal flexion extension, supination, pronation. You just can't have them abduct their shoulder and put them through a throwing motion early on. So you can start them moving as long as they're comfortable. Some of these throwers, Andrew starts moving within 3 to 6 days. So I usually start moving them within 7 to 10 days.
Dr. Chhabra, I remember when Jeff Dugas was here, he was talking about his internal brace for some of these partial tears. He was getting people back a lot quicker, albeit a lesser injury. I mean, what do you think about putting an internal brace in, or basically a suture anchor based, I guess you can't really call it a reconstruction, more or less an internal
repair. So yeah, so I briefly mentioned that earlier on, but he's did it in high school pitchers and is now starting to do it in pro pitchers, and he's done a fair number. And I actually learned from him when I was doing a AOSSM fellows course, and him and I were teaching the fellows how to do a UCL reconstruction. So I was learning more than I was helping, really. But this is a biologic, a collagen tape is what they're using, and I mentioned. And where they find the UCL avulsion, it's an acute injury or partial injury, and they basically put a suture anchor and lay the tape over and repair the ligament. Now that he's gotten some pictures back at 6 months or even faster, and the question is it going to be as durable as a UCL reconstruction? And that still remains to be seen. And I also mentioned that my technique now is not only do I use a graft, but I use that same tape that he uses for a repair. I lay that tape on top of my graft and secure it with my interference screws. So that's an additional, to me, add more collagen, because you want more collagen on the medial side of the elbow. But the biologics, as Dr. Guafni mentioned, where are the advances are going to come? I think the rehab advances are going to be limited right now. I think it's going to be biologics that are going to accelerate potentially healing of this ligament. That was some of the argument of PRP for partial ligament injuries, but that hasn't really been shown that it works consistently. But that being said, this repair technique with a collagen or a biologic tape can be used, but again, we need much larger number of cases and more people doing them across a wide spectrum of throwers, not just high school players who are in their senior year and are not planning to pitch in college, because he had a very limited scope of patients, and now he's starting to go into the professional pitchers. So I think we're going to have to wait and see how that plays out.
So you said that you switched from a docking technique to a interference screw technique. What drove that decision to switch, or are you doing 100% interference screw? Or do you still do some docking for some?
So no. So what I really liked about the palmaris tendon length, the max you can get sometimes is 17 centimeters or 16 centimeters, and in some of these big elbows, even with a docking technique, you're just I had difficulty tensioning sometimes. I didn't get as much consistent tensioning, and that's the biggest complaint about docking. You can put it through bone tunnels distally, but then as you make one single bone tunnel, you have to cut your graft so that it fits into the tunnel. Can you still hear me? I'm sorry.
Yeah, sorry about that.
Yeah, so when you have to, there's a lot more fiddle factor trying to tension your graft when you're doing a docking technique. What I really like about the bone, the interference screws, and that's becoming. You still hear me, right? Yep.
Yeah.
What it's becoming more and more common with my colleagues who are doing these reconstructions is that you can tension the graft and then you have extra graft. So I bring the extra graft over, and sometimes I have a 3-strand repair because of the amount of graft I have with the interference screw technique. But regardless of what you do, you're doing the same thing in all cases. And I just like the fixation of some of these interference screws now, because sometimes when you're making bone tunnels, you'll have a thin bone tunnel and then you worry about the tunnel breaking as they're beginning to throw. But with the interference screw, you're burying the tendon into the bone and you're getting healing of the tendon within the bone, and you can tension it much more reliably, and you have excess tendon that you can bring back down, and you get a double barrel, even a triple barrel repair of the UCL. So it's really a stout repair, and it's just, to me, a very reliable way to do it and get the right tension. Something I learned from you sports guys. You guys
Exactly.
like to use interference screws for everything, right?
You got to use implants, right?
Yeah, right.
So Justin Divitt asks, with all these different techniques out there, we try to educate coaches in our area as well. Do you see more UCL injuries with specific types of mechanics, such as the inverted Y or an adapted modified inverted W or anything like that, or a sidewinder or something like that?
That's a good question. And I mean, Brian McGuire may be one of the best people to answer about this. What I can say is that there are some training techniques that seem to create more elbow injuries in throwers. And Brian and I lived through this, and Winston did too. The heavy ball that they use makes me nervous. Some of the techniques they use tend to put a lot of stress or fatigue the shoulder and the elbow, and can cause elbow injuries. But regardless of whatever training technique they're doing, Justin, it really comes down to fatigue and loss of their normal mechanics in their throw, and I think that results in the injury. And some of what's really frustrating often for our high level pitchers is that not when they're not pitching, they're in the weight room and they're lifting and they're constantly trying to get stronger and so forth. So they're putting a lot of stress across their elbow and shoulder. And then as soon as their season's done, not now because of COVID, they head right off to their summer league. So it's frequently they don't get enough time to rest and recover. And if they go from their season to their summer league season, eventually they're going to fatigue enough if they're not careful, and they'll have a significant number of pitch counts. We see this more in high school than in college. In college, in many ways, there's some control and supervision from the trainers, but not always the case in some of the younger pitchers. So I still think pitch counts and the different different training techniques can definitely contribute to, if they're not done right, and if they're done in excess, can contribute to injury.
Outstanding. Well, I think we're all good as far as questions. Any other questions from the crowd? One more thing on the chat. Just a thank you. So I did want to just give a quick shout out to, again, I'm trying to, my goal, just to let you guys know, is to make UVA Orthopedics basically the educational resource for the region. And so I did start this YouTube channel, and I do have these playlists here. I hope the screen's being shared. Is the screen being shared?
Yes.
Yeah, so you can kind of see these different channels we've made. And so, like, for instance, these videos I'll be putting on this Evening with UVA Orthopedics channel, so you can go back and see some of the ones you might have missed in the past. And I really want to keep this up, and so I'd encourage everybody to give me ideas as far as topics they want to hear about, and different faculty they might want to hear about too. So you can just see. You can see what my kids are watching too. A lot of Trolls World Tour. But I would also just tell you, we had an excellent grand round speaker this morning, Robin West. And I would encourage you guys, if you want to see something really cool, to go and listen to her story from this morning. So Again, Dr. Chhabra, that was really, really great. I really appreciate you coming on and taking part in this and your excellent treatment of upper extremity injuries here. So thank you so much, Dr. Chhabra.
Great. I really enjoyed it. Happy to come back in the future if there's interest to talk about some other injuries too as well. So, but thank you, Winston, for organizing this. This is fantastic. And I'm glad that UVA Orthopedics can continue to help continue this dialogue with our community. And it's really fantastic. So thank you all for spending time this evening, and reach out anytime if you have any questions. And again, it's a real privilege to work with many of you on a regular basis, and thank you for helping us care for our patients.
Great. Thank you so much, Bobby. Have a good evening, everybody.